So we are live now. With all your permission, I'm starting this session.
Okay. Yeah.
Good evening, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, Dr. Surya Kant sir. Sir is a professor and head of Department of Respiratory Medicine, that is KGMU Lucknow, and past president ICS, NCCPN, and ICAAI, past national vice chairman of IMA and IAMS. And today he is going to discuss on a topic management of asthma with allergic rhinitis. World Asthma Day. Let me tell you overview of the topic. Management of asthma is become very important these days. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you, dear, for setting the ball rolling. And World Asthma Day, as you know, since 1998, the Global Initiative for Asthma, that is GINA, it's an international body for asthma, that is celebrating on every first Tuesday of every May every year. And this year, today is 2nd May, and this is the first Tuesday. That's why we are celebrating World Asthma Day today. So for today's topic, I'm really thankful to the IJCP group that they have given this wonderful opportunity for interacting with you people on management of asthma with allergic rhinitis. Allergic rhinitis is the most common comorbid condition of bronchial asthma, and it's a very important to treat properly the allergic rhinitis for the smooth control of asthma and better outcome of the treatment of asthma. So first, I'm discussing a case scenario. A 30-year-old obese woman presented with chief complaints of breathlessness on adjacent since last 6 months with on-off cough without expectoration, no history of orthopnea, fever, weight loss, and appetite. Patient visited a general practitioner where she was prescribed asthma-rhinitis medication. After taking proper history by the specialist, within 2 months, patient sign and symptom deteriorated and patient was referred to specialist. After taking proper history by the specialist, the patient this history reveals the nasal congestion, nasal itch, rhinorrhea, and sneezing, allergic conjunctivitis, that is including redness, tearing, and itching of the eyes, family history of atopic diseases, as patient had history of persistent cold in specific season. Patient also had history of ingestion of second generation oral antihistamine on occasional basis. Physical examination of this patient revealed persistent mouth breathing because of nasal blockage, rubbing at the nose or an obvious transverse nasal crease, frequent sniffing or throat clearing, allergic sinners, that is dark circles under the eyes that are due to nasal congestion, signs transverse nasal crease, allergic sinners, allergic salute signs are also present. Investigation, blood investigation and lung function test were done by the specialist. Blood routine investigation are within normal limit with elevated eosinophil count and elevated serum Ig level. Spirometry, that is the lung function, reveals the reversible airway obstruction that is suggestive of bronchial asthma, and thus a history of allergic rhinitis with bronchial asthma was made as serum Ig was also elevated. Now, the patient was advised to avoid dust and cold weather as they are the precipitating factor for the allergic rhinitis as well as the asthma. Inhaled therapy with inhaled corticosteroid with long-acting beta-2 agonist was started. Combination of montelukast plus blastine, that is nicotine receptor antagonist, and a combination of antihistaminic was started at night. Intranasal spray was also added. Steam inhalation was also advised, as well, creating a lot of important benefit for the allergic rhinitis as well as asthma. Patient was followed after 3 months. Patient has improved, no symptoms. Now, what is allergic rhinitis? If you see the cut section of the nose here, you can see on the left side that is normal nasal mucosa, and on right side the allergic rhinitis, a lot of redness and congestion. So allergic rhinitis is an inflammatory disorder of the nasal mucosa induced by allergen exposure triggering IgE mediated inflammation. Now, a lot of definitions have been given. To summarize, I want to clear here all confusions. Remember the 4 definitions. What is rhinitis? It's the 2 or more symptoms of anterior or posterior rhinorrhea, sneezing, nasal blockage, and or itching of the nose for more than 2 consecutive days for more than an hour. Allergy is objectively reproducible symptoms or signs initiated by exposure to defined stimulus at a dose tolerable by normal subjects. Hypersensitivity means the altered immune response to an antigen that can cause damage. Atopy means the tendency to become sensitized and produce serum Ig in response to ordinary exposure to allergen. Now, worldwide, if we see the epidemiology of allergic rhinitis or the magnitude of the problem of allergic rhinitis, then of course in different the continents you can see Europe is having high prevalence, that is 17 to 29%. Asia is having variable prevalence of allergic rhinitis from 11 to 63%, and similarly other continents. So it's a pan global problem of allergic rhinitis. India is having roughly incidence of about 20 to 30% cases. So allergic rhinitis, if you see what are the common triggers, what are the common causes for allergic rhinitis, and we'll found that dust mites, dust and pollen, molds, pets, foods and beverages, that is fast food mainly, airborne irritants, they are the main culprit for the precipitation of symptoms of allergic rhinitis. And symptoms, if you see, the sneezing, rhinorrhea, congestion, nasal drip, and of course itching eyes, conjunctivitis, and sore throat, itching, then of course the snoring, mouth breathing, and of course headache and congestion also. So I think this is the whole spectrum of the symptoms and signs of the symptoms of the allergic rhinitis. And if you see signs, so apparently from distance you can see that it's a case of allergic rhinitis. So as the allergic rhinitis patient, they keep on the rubbing the nose. So there is this is the sign is called allergic salute, and always there's a you can see transverse nasal crease because of the repeated rubbing, and allergic shinners, that is congestion all around the nose. So these are some important physical signs for allergic rhinitis, which you can see distance at a distance even. So the classification of allergic rhinitis based on the time of occurrence of symptoms can be seasonal or perennial or occupational. I'm not going into the details. Some indoor allergen, outdoor allergen are the, but the main classification is based on the duration of symptoms and the severity of the symptom and the duration. Now, so the allergic rhinitis can be intermittent or persistent. If the symptoms are less than 4 days per week or for less than 4 consecutive weeks per year, then it is called intermittent. Otherwise, if it is more than that, this is called persistent. More than 4 days per week and more than 4 consecutive weeks per year, then it is called persistent. Now, both intermittent persistent can be mild and moderate severe. So, duration of symptom has two classification, two types, that is intermittent and persistent, but the severity has got two types of the grading, that is mild disease or moderate or severe disease. In mild disease, we have the normal sleep, normal daily activities, normal work on or school, no troublesome symptoms. While in moderate to severe disease, one or more items are present like abnormal sleep, impairment of daily activities, sport, leisure, problems caused at work or home or school, troublesome symptoms are present. So that is how we differentiate between the intermittent and persistent, mild and moderate severe. Now, what treatment modalities you have for allergic rhinitis? We have non-pharmacological modalities and pharmacological. In non-pharmacological, first and foremost is the avoidance of allergen and the nasal irrigation, popularly known as Jalneti. So you can prescribe your patient, although you are the doctor of modern medicine, but Jalneti is very good maneuver for the symptom relief for the allergic rhinitis, and you can also prescribe. And then, of course, you can also try some allergologists in this country. They are practicing the allergen-specific immunotherapy. That is also having a good impact on the allergic rhinitis. Now, pharmacological treatment means the drug treatment for the allergic rhinitis can be the oral antihistaminics, can be the intranasal corticosteroids, intranasal antihistaminics, leukotriene receptor antagonist, and combination therapy. So to begin with, if the patient is having moderate to severe kind of allergic rhinitis, whether it is intermittent or the persistent, then of course the combination therapy is the usual choice, and then one by one you can de-escalate the therapy. Now, ARIA guidelines, that is, ARIA is the body that is called allergic rhinitis and its impact on asthma starting from 2000, sorry, and even the latest guidelines available are earlier 2020. They are recommending the oral antihistaminics. The same kind of recommendations are there, whatever we have discussed. Other bodies also have the same kind of recommendations. Now, important factors when selecting the most suitable anti. How you will use select the which antihistaminic should be selected. So a lot of factors are working how to select an antihistaminic. For example, patient is a non-worker or a worker. For example, patient is executive class, so you have to select the non-sedative antihistaminics. Similarly, you have to see the efficacy and safety, whether patient is having a liver disease, so you cannot prescribe the drug which is causing hepatitis or hepatotoxic. If the patient is having associated kidney disease, you cannot prescribe antihistaminic, which is nephrotoxic or similarly other comorbid condition. Lack of sedation, lack of psychomotor impairment, lifestyle of the patient, which type of patient you are dealing with, and cardiac safety, liver safety, and renal safety. Everything you have to consider. And then, of course, a special patient population, whether pregnant, elderly, or the pediatric population. Now, if you see the comparison, this is the comparison table of most popular antihistaminic. First drug is called blasting. Second column is cetirizine. Third is levocetirizine, and fourth is fexofenadine, and last is deslorelizine. And if you see that H1 receptor selectivity means selective antihistaminic, then blasting has got 3 plus, levocetirizine, cetirizine 1 plus, 2 plus, fexofenadine 1 plus, and deslorelizine 2 plus. If you see the dose adjustment in renal impairment, that is not required by blasting, but it is required, not required for blasting and fexofenadine, but it required by all other antihistaminics. If you see the dose adjustment in hepatic impairment, not required by blasting and fexofenadine, it is required by others. Dose adjustment in elderly, not required by blasting and fexofenadine, otherwise it is required by all. Clinically relevant drug interaction, yes, there is no interaction for the blasting and the cetirizine, but some interactions are available. Although there is no interaction for deslorelizine also, but certain interactions are available with other antihistaminics. Contraindication, there is no contraindication with fexofenadine and blasting. However, there is a lot of contraindication with other antihistaminics. And the number of area recommended antihistaminic properties out of the 10, all 10 marks given to the blasting, 9.5 given to the fexofenadine, and 6.5 given to the levocetirizine and deslorelizine, and 6 given to the cetirizine. So that is how we compare the efficacy, safety of the various antihistaminic, and tomorrow onwards you can prescribe accordingly. So what can be the complications of allergic rhinitis? The bronchial asthma, the chronic otitis media, hearing loss, chronic nasal obstruction, and sinusitis. Now, allergic rhinitis and its impact on asthma. The previous guideline area has already given, and so many other guidelines have also given. Now, I used to say since 1996 for last 26, 27 years, that nose is like the first floor of the house while lung is the ground floor of the house. If you have two-storied house, then first floor is the nose and upper airway, and of course ground floor is the lungs. If there is a problem in the nose, that is in first floor, of course there will be problem in ground floor also. So the nose, nasal cavity, pharynx, larynx, trachea, bronchi, and their division lungs, they are the part of the upper and lower respiratory tract, and they are interrelated. And again, this is proven that approximately 80% of the patients suffering from bronchial asthma having comorbid condition of allergic rhinitis. So, and approximately 1/3 of the patients having allergic rhinitis have the risk of developing bronchial asthma. So, you have to understand this link. Now, understanding of asthma etiology in ancient times, first time the asthma described by Hippocrates, then the link between the allergic rhinitis and asthma was first described in 2nd century by the Galen. And of course, this is the asthma treatment evolved over the decades from 1970s when it was considered as bronchospasm. And then, of course, then a lot of drugs started, theophylline, SABA, and so many other drugs, and latestly tiotropium and even the biologicals since 2015 onwards. Now, what is asthma? Asthma is a heterogeneous disease characterized by variable respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough, and variable expiratory airflow limitation. It is usually associated with airway inflammation. Asthma is the most common chronic non-communicable disease affecting over 260 million throughout the globe, and in 2019 with 37.9 million in India, and caused 4,50,000 deaths in India. So global, I mean, share is also in India, that is too high, but mortality is definitely very high. 43% of the global asthma deaths, they are occurring in India. Bronchial asthma, what is bronchial asthma? It is basically the result of interaction of genotype, susceptible genotype of the asthmatic patient with interaction of certain environmental factor, and that's why we are also getting the family history, because it is the genotype susceptibility disease. Now, in public domain, I used to ascribe asthma as that if you touch any leaves of the any plant, nothing will happen. But if you touch the leaves of touch me not plant, then of course they will shrink. So that is how the susceptibility of the bronchi of the asthmatic patient. This is my MBBS final year slide where I used to describe the asthma pathology by A, B, C of asthma. A stands for airway hyperresponsiveness, B stands for bronchoconstriction, and C stands for chronic inflammation. And these are the major risk factors, including the family history of asthma and history of atopy, tobacco smoking, outdoor-indoor pollution, biomass fuel. Thanks to Prime Minister Modi ji, due to this Ujjwala Yojana, 11 crore families, poor families of this India have been given the free LPG connection. That's why they have, of course, get rid of the biomass fuel exposure also and their side effect also. Respiratory virus infection, influenza and parasyncytial infections, and the occupational exposure and associated comorbid condition are the major risk factor for the asthma. Clinical challenges in management of asthma in India. 3. Majority of the Indian patients remain undiagnosed or wrongly diagnosed. Those who get diagnosed remain poorly or inadequately treated. Most of the Indian patients continue to be on oral medications rather than inhalation therapy. This special article we wrote with the Indian Medical Association in 2020. That is the published in Journal of IMA, and this is the executive summary of the recommendation on management of asthma and primary care. Means how the doctors at PSC level, CSC level, and village level, even how can they manage asthma. That is the important document. You can go through this document, available in the Journal of Indian Medical Association. This journal is now available online. You can search for the February 2021 issue. Now, my way of teaching for the asthma is the 7D approach for the management of asthma. First D is stand for doctor. So doctor should be asthma trained doctor. Second D is stand for diagnosis. Third for drug. Fourth D for doses. Fifth D for devices. And sixth D is the deliberation. And of course, sixth D is not D, but it is the adherence. Doctor, of course, should get the important knowledge from a very important platform, not this type. Diagnosis is very important. The breathlessness, wheeze, cough, and chest tightness leading to major symptoms, and more than, of course, then you can confirm by lung function test. Evidence of obstruction is shown by in spirometry by FEV1 FVC ratio less than 70%. Post bronchodilator FEV1 more than 200 ml and 12% change, and a PFR, that is a small instrument of peak flow meter. In adults, average diurnal peak variation is normal 10, more than 10%. Then it is considered to be asthma, and in children, this is more than 13% supposed to be the. This is the very small instrument that is called peak flow meter, and it has got green zone, yellow zone, and red zone by which you can predict whether you are in the normal asthmatics or you are at danger of developing asthma attack. Now, differential diagnosis. I used to say in my, of course, public domain lectures that the differential diagnosis of asthma means every dyspnea is not asthma. I used to say in Hindi, जैसे हर चमकती चीज सोना नहीं होती, वैसे हर फूलती हुई सांस asthma नहीं होती. So important differential diagnosis with asthma is chronic obstructive pulmonary disease, GERD, gastroesophageal reflux disease, pulmonary tuberculosis, bronchiectasis, and cardiac failure. These can be the major, of course, important the differential diagnosis of asthma. And then if you see the asthma and comorbidities, then they are very important. If you are treating asthma alone, you will not able to control all the symptoms of the patient. So you have to look for the comorbid conditions. An important, most common comorbid condition is the allergic rhinitis. Then, of course, other can be the hyperventilation, psychopathies, smoking, nicotine dependence, COPD, respiratory infections, other conditions like atopic dermatitis, ABPA, bronchiectasis, hormonal disturbances, obstructive sleep apnea, obesity, and GERD and chronic sinusitis. So you have to look for all comorbid condition on physical examination. There is a presence of dilated diffuse bronchi or polyphonic wheeze, by which you can, of course, confirm the diagnosis of asthma. Drugs, what type of drugs you can use? Then, of course, you have to see that asthma medication can be of three types: the controller medication that prevent that and control the inflammation of the bronchi, reliever medication that is bronchodilator, and then, of course, add-on therapy that is therapy in severe asthma. So all three types of medications we can use. Why we use two types of medication ordinarily? Because asthma is a disease of spasm and swelling. Spasm needs a reliever and swelling needs a preventer. So reliever means the bronchodilator and preventer or controller means anti-inflammatory, that is inhaled corticosteroid. This is the GINA guideline 2023, and you can see the step up approach and step down approach after a review of 3 months. So the another the group of medication, that is the controller medication. This can be the inhaled corticosteroid, budesonide or cyclophosphamide, fluticasone, beclomethasone, and can be the ICS LAVA combination, that is inhaled corticosteroid plus long-acting beta-2 for example, combination of beclomethasone plus formoterol, budesonide and formoterol, fluticasone and valentrol, fluticasone and formoterol, fluticasone and salmeterol. Different combinations are available, and they are popularly known as ICS LAVA combination inhaler. All both these drugs are available in a single inhaler. And of course, montelukast is the very important also controller drug. Reliever drugs can be the SABA, that is salbutamol or terbutaline, usually in the inhalation form. Low dose ICS formoterol combination, they are also working as a reliever, beclomethasone plus formoterol, budesonide plus formoterol. Only formoterol combination can work as a reliever, not salmeterol or valentrol. Short-acting anticholinergic like epinephrine bromide can also be used as a reliever for the drugs. And then, of course, a lot of add-on drugs we can use. We can use tiotropium for more than 6 years of age, omalizumab, that is biological, for more than 6 years, mepolizumab more than 12 years, more than 18 years, and benralizumab more than 12 years. Duvlimab, which is not available right now in India, can be used for more than 12 years. And systemic corticosteroid we can use off and on as per your clinical decision. The doses, we have low dose inhaled corticosteroid, medium dose corticosteroid, high dose inhaled corticosteroid. We used to compare with budesonide. Budesonide is 200, 400 microgram dose per day is the low dose. 400 to 800 dose per day is the medium dose, and more than 800 per day is the higher dose of the inhaled corticosteroid. What devices you should use? There is a lot of debate whether you use PMDI. DPI means the inhaler or rotahaler. But in the Department of Respiratory Medicine, we have developed a protocol. This is called departmental protocol, developed by me. And that is for asthma, there is a clear-cut choice. For 0 to 3 years, you can use MDI with this spacer, with face mask or baby mask. And of course, otherwise you can use nebulizer also during emergency. For 3 to 6 years, MDI with this spacer. From 6 to 60 years, you can use either dry powder inhaler or the breath actuated inhaler. For more than 60 years, you can use either the MDI with the spacer or breath actuated inhaler, or you can nebulizer depending upon the clinical situation. So deliberation is also important. That should be part and parcel of asthma management, means communication to the patient. Adherence is also a very important. Very important celebrity has said that drugs don't work in patients who don't take them. And in India, if you see that 67% asthma patient in India reported exacerbation the previous year. Why? Because they are taking drugs regularly. 78% asthma patient in India reported missing work or school in last 1 year, at least 16.5 days, and that's because of irregular therapy. Only 36% and 50% of the Indian asthmatics use controller and rescue medication inhaler. So that is the situation, and that's why one survey says that in India we have around 4 crore people suffering from asthma, but 40% are uncontrolled as far as symptoms are concerned, and 60% are the partly controlled. So how to select a biological? Although this is the domain of the expert, but anyway, I will briefly summarize in one slide that asthma phenotype. If it is severe allergic type, you can choose biological anti-IgE, that is romalizumab. If it is eosinophilic asthma, you can choose anti-leukin 5 or anti-leukin 5R, mepolizumab or benralizumab. If it is neutrophilic asthma, you can use bronchial thermoplasty. If it is not available, then you can use macrolide, that is azithromycin. Bronchial thermoplasty is a very typical complicated procedure by which by using the thermal energy, we decrease the muscle size. This is very important slide. at what thing you can do so that you can assess whether the patient is controlled, well controlled, partly controlled, uncontrolled. Only ask the 4 questions. The 4 questions are that in the past 4 weeks or past 1 month, if there was any daytime asthma symptom, yes or no, yes, 1 number, no, 0 number. Any night waking due to asthma in last 1 month, yes, 1 number, no, 0 number. Relief needed for symptoms more than twice a week means reliever inhaler, salbutamol or levosalbutamol inhaler. Yes, 1 number, no, 0 number. Any activity limitation due to asthma in last 1 month, yes, 1 number and no, 0 number. If the score is none of these, 0, this is patient is well controlled. If 1 to 2, this is partly controlled. If it is more than that, 3 to 4, it is the uncontrolled. So the asthma treatment in summary basically can be the pharmacological treatment, which we have already discussed. Now coming to the non-pharmacological treatment, what additional we can do? Cessation of smoking is mandatory. You cannot continue 2 things, smoking as well as inhaler. Physical activity, always allow the physical activity for the patient. Don't restrict on the bed. Healthy diet, vegetarian diet with green leafy vegetables and fresh fruits is the essence for the asthma. You should not advise the patient to take non-vegetarian diet or the fast food. Weight reduction, obesity is a risk factor for asthma exacerbation. So weight reduction is also non-pharmacological. And most important, the breathing exercise. The GINA also considers that breathing exercise may help as a non-pharmacological therapy. And of course, last but not least, the avoidance of occupational exposure and other, of course, the triggers. Now, a little bit about the breathing exercise. So, or it is in India, it is called yoga, and Adi Yogi is the first teacher. Shivji is the first teacher of yoga, and later on Swami Vivekananda and Honorable Prime Minister of Modi, they emphasize on yoga, and that's the idea of International Day of Yoga was first proposed by the Prime Minister Modi, and during his speech at the United Nations General Assembly on 27th September 2014, and the first International Day of Yoga was celebrated all over the world on 21st June 2015. And this is the, I think, first PhD on yoga and asthma, which Dr. Shruti did under my supervision. And this was the registered in 2009 and of course the awarded in 2014, around 9 years back. And this study shows also used various jogging exercises, a lot of yoga like Gomukhasan and Bhujangasan, Parvatasan, Dhanusasan, and so many asanas were Tadasan, Shavasana, Naukasan, these were used basically for the relief of the asthma. And then, of course, she also did the postdoctoral fellowship that is awarded by Indian Council of Social Sciences Research, New Delhi. And this is the thesis submitted in 2022, and still we are doing. So since last 15 years, I'm working on this field, yoga and asthma. And of course, we have got a lot of publications. And this is the yoga room in the Department of Respiratory Medicine, KGMU, where we practice, advise the patient, and a lot of benefits of yoga are there. But yoga is not the alternative of the inhalers, and yoga can be the only adjuvant therapy. That's we have to consider. Nobody can say that मैं yoga कर रहा हूँ तो मैंने inhaler बंद कर दिया. ऐसा नहीं हो सकता. In summary, I can say that presence of the characteristic symptoms and their pattern along with findings on physical examination, it's sufficient to suspect asthma. Asthma is a clinical diagnosis still in 2023. However, it can be confirmed by the lung function. Asthma diagnosis in young children is mainly based on recurrent symptoms, patterns plus assessment of family history and physical finding along with some diagnostic criteria. Inhaled form should be considered as a compared to the systemic formulation, oral or IV, to improve the clinical outcomes in asthma. Inhaled medications work fast to improve the symptoms and outcome. Inhaled route is safer as compared to oral or IV route. ICS containing controller treatment should be initiated immediately as needed in mild asthma or daily to reduce risk of serious exacerbations. So thank you very much for attention. So now I'm of course taking out my slide from the presentation.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participants on their practice. We have received some questions. Shall we take with all your permission?
Yeah, sure.
The first question I can see is, what is the role of antifungal medication in the treatment of asthma?
In asthma per se, there is no role of antifungal. Only one situation, that is called allergic bronchopulmonary aspergillosis. Initially, it's a basically hypersensitivity. Initially, we treat this with oral corticosteroids along with the inhalation therapy. And if the patient is not responding, then only we can introduce the antifungal. Otherwise, there is no role of antifungal in bronchial asthma per se.
Okay, thank you so much, sir, for explaining it really well. Moving forward, I can see another question. The another question is that which guidance are the best in your opinion with regard of allergic rhinitis?
ARIA guidelines are the best guidelines. We all usually follow them. So I also recommend that you should follow the guidelines of allergic rhinitis and its impact on asthma. That is called ARIA guidelines.
Okay, thank you so much, sir, for answering, sir. We will be taking last question for today's session. The question is, what is the role of vitamin D3 in the acute rhinosinusitis in the management of asthma?
Vitamin D3 has no role in any acute illness, including the acute rhinosinusitis or acute bronchial asthma. Vitamin D is very important for immunity boost up. So on most of the Indians, they are lacking. So vitamin D should be more than 30. And you can, you see, have the test done for the vitamin D levels. And if it is less than 30, then of course you can dip the 60,000 international unit of vitamin D once a week for 2 months. And then maintenance therapy can be given 60,000 international unit per month. So this can be given, and a prophylactic dose of 6,000 international unit can also be given. But this is a generalized boost up for the immunity, and it can prevent you from the various diseases, various ailments. So that's very important as a part of disease prevention. But in acute setting, it has got no role.
Okay, thank you so much, sir, for answering all the questions, sir. As I can see, there is no more question from the participant end. With all your permission, shall we conclude this session? Okay,
Yeah,
thank you
thank
so
you.
much,
Thank you
sir.
very much. Namaste.
Welcome, sir, and hope to see you again with different topic. Till then, take care of
Sure.
yourselves.
Sure.